And again, thank everybody for joining the Tuesday evening study group. We have a wonderful special guest here with us this evening, Dr. Shouresh Charkhandeh, who is going to be presenting MATRx, the new standard of care for oral appliance therapy. So thank you so much, Dr. Charkhandeh, for joining us tonight.
My pleasure being here. Thank you, everybody, for joining us tonight as well.
And we also have Rose on the line with us to help us through the presentation. Hi, Rose.
Good evening. How is everybody?
So we're all doing great. Everybody else, I believe, is mute, so I'm going to speak on behalf of everybody.
Very good. Well, we're really excited to have Dr. Charkhandeh with us, and we will be working with Shouresh in Chicago for a seminar on June 13th and 14th. It's our two-day seminar, a successful implementation of dental tooth medicine with 16 PE credits. So we hope you can join us now. And if you'd like to register, just visit our website or give us a call. And our next course is with Dr. Ken Smith. That course is in Boston, and that's coming up pretty quick here. That one is on April 4th and 5th, and so that's another opportunity to see another great speaker with a good course.
Kent is, of course, an amazing speaker.
He really is.
Yeah.
Really is.
All right. Well, without further ado, Dr. Charkhandeh, we're excited to hear what you have to say about the MATRx.
Okay, for sure. Welcome, everybody. I was talking to Courtney. I'm going to try to keep the presentation to about 30 minutes or so. I hope everybody can hear me while I'm using one of these iPhone microphones. I'm not sure how it's working out, but if at any point, if there's any problems, just let me know. But tonight, I'm very excited to talk about just a different aspect of dental medicine. It may not be necessarily directly related to oral appliances or the protocols that we follow these days, but it's going to be mostly related to improving our practice of sleep medicine in general. And I think that's going to become more and more important as we see a trend towards oral appliances becoming more of a standard of care and not just an anomaly in the whole medical system. Because as we all know, about 5% of patients are receiving oral appliances and 95% are still getting CPAP. So what I want to kind of focus on is the importance of long-term management of the patient, and regardless of their treatment modality. And as Courtney has the next slide up, talking about CPAP therapy, we all know that is the standard of care as of today. It's been around since 1982, a few years after Dr. Remmer first showed that sleep apnea is caused by anatomical problems. And real belief for many years has been, when in doubt, pressurize this now. And it's one of those things that will prove for many, many years. And as we all know, it's a very, very efficacious therapy, but not necessarily as effective. And the difference between efficacious and effective is, efficacious is a therapy that is working in a lab environment, in a trial environment, and effectiveness really has to do with real life. And one of the problems we have with CPAP, although it's a great, great efficacious therapy, is going to be the poor compliance. And that's one of the main reasons that we've been struggling and we're looking for alternatives at this point. That's why the medical society is looking for alternatives. It is a great, great therapy, but the poor compliance is what's creating the problem there. You can go on the next slide, Courtney. I told you I'm going to go through the slides really quick. I warned her about this one. And so we need an alternative. We know that right now, and that's where all the effort has been going on in the past 10 years. And as we've seen since 2005, 2006, when the new guidelines came in, oral appliances are getting a lot more popularity. As an alternative therapy, we know oral appliances are accounting for about 5% of the total OSA therapy, although it is preferred by most patients, and we know the compliance is better, but it's being underutilized. And there's a lot of research that is going in showing the efficacy of the appliances and how great they are, but it's not necessarily creating the results that we want in the real practical sense. So realistically, we know 60% of the patients can be treated with oral appliances, but we only see 5% of them. So what I wanted to kind of address tonight is let's look at things in a different view. Let's look at it from a different aspect. And let's take a look and see what are the concerns that prevent the sleep physician from recommending or prescribing oral appliances. And I talked to a lot of sleep physicians. I joined a lot of their conference calls. I joined a lot of their meetings. And the four main things that keeps on coming up, and which I would say the important ones, some of them are just prejudice and they just don't want to deal with oral appliances. Some of them really don't believe in them. Those are not the ones that I'm going to talk about. But there are four really real valid concerns that involve oral appliances. One is treatment outcome compared to CPAP. Two is compliance. Although we say the compliance is better, but we've never had it measuring compliance. So it's always patient reported. It's always been based on what the patient tells us. And it's very hard to prove that is the exact same as an objective compliance. Of course, the third biggest issue is the long-term side effects. And we know that's been around. There's a lot of studies that's been shown in that area, and we know we have side effects. In some studies, we had higher percentages, and some studies we had lower percentages. But at the end of the day, it is there just like any other medical therapy. And last but not least, it's patient selection. So what I like to do is just go over all these four concerns, because in the past 2 years, we've seen a lot of new research that comes out that I truly personally believe it's going to change the whole landscape of sleep medicine, and more importantly, dental sleep medicine. One of the biggest studies that came out was a randomized controlled trial done out of Australia with the Sestuli group. And what they showed was in the short term, health outcomes in patients with moderate to severe sleep apnea was similar after treatment with CPAP and mandibular advancement devices. And that was a very, very, very large study, and it was very interesting because it was done in moderate to severe patients. So these were patients that were given CPAP, and they were followed up after a few months, and then they were given an oral appliance, and they were followed up after a few months. And some of these patients were not fully treated with oral appliances, so maybe their AHI and RDI got reduced from 30 to 17, but it wasn't necessarily that definition of success, which is in some books, RDIs are below 10 and reduction by 50%. However, the interesting point was, regardless of that number, there is still the health outcomes, which is the most important thing, because we're not treating numbers, we're treating patients, and we want them to be feeling better. And that's what we really care about. It was higher. And these findings strongly challenged current practice parameters. And that was published in the Journal of Sleep not too long ago. So where we're at today, we're looking at these randomized controlled trials with CPAP versus OAT, and we know that OAT can be better. So if we could have a better oral appliance patient selection, maybe oral appliances could be actually better than CPAP. And that's where we kind of heading at. And I'll get back to this point down the road at the end of the presentation. But the reality is we know, even though our patient selection is not the best in oral appliances at this point, it still can be as effective. The next point is going to be compliance, and we talked about that. That was the next concern, which is objective versus subjective. There was another good study done published in Journal of Sleep, which basically showed that a statistical analysis showed that there's no significant difference between objective and self-reported oral appliance compliance data. So it takes all the doubt out of it. So when the patient tells you they're wearing the appliance 90% of the time, chances are they're wearing it pretty close to 90% of the time. But even if that's a concern for your medical doctor or for the sleep physician, the reality is we have newer technologies that are been proven, they're FDA approved, and we're just waiting to come out in the market, such as DentiTrack. And those are the compliance chips that can be inserted in different appliances now, and we can actually have objective compliance recording as well. So that puts the second point and the second concern out of it as well. So we know oral appliances work as well. We can measure the compliance. And before I get to the next point, which is the efficacy of the appliances, I would like to talk a little bit about long-term side effects. I didn't put a lot of slides on that section because a lot of side effects, as we all know, with better appliances, with better bite registrations, with better material, they seem to be getting less and less and less. And I know a lot of physicians don't have as much concerns about that, and we can always reverse a lot of those side effects now that we know how we can manage these patients. So it basically brings us down to the last concern that a physician can have, and that would be the consistent efficacy of oral appliances. So we know oral appliances work. We know they work in 50 to 60% of patients, and they work really well in those patients. what we're banking all our claims and everything in dental sleep medicine on. But the reality is which ones? And we know they work, but if I gave you 10 patients, there's a lot of different ways of knowing who it doesn't work for, but we cannot still say who it works for. You can go on the next slide, Courtney. So that's where the problem is, and that's one of the biggest questions. I was at a medical meeting not too long ago, and one of the sleep physicians came up to me, and his question was, I understand oral appliances work, but if I do send you a patient, can you guarantee that if this is going to work for them? And for those of us who's done it long enough, we know we can never guarantee an oral appliance working. Because if we do that, we're basically lying to the physician and lying to the patients, because there's no way of knowing if it works or not. And that was his point. Is like, if I put them on a CPAP, I know it works. I'm taking the liability out of it. And if it doesn't work, then I'm going to put an oral appliance. And the second part of it, of course, is the next question was, where are you going to set the manual? Where are you going to take the bite registration? And his point was, I'm talking to a lot of different dentists, and every one of them has a different way of approaching the bite registration. And none of them seems to be backed by research or any kind of clinical control trials. It's mostly clinical practice. Can you guys hear me still there? I lost you on my screen for a second.
No, you sound great. We hear you.
All right, perfect. Sorry about that. I just completely lost everything. But the reality is, we actually, not only we don't know who it works for, and there is no research or data that shows that, we actually don't know where to put the bite. We have a starting point, and then we do the calibration. That's what the conventional oral appliance therapy is today. So if I was going to summarize everything, the reality is, up until today, sleep physicians and the dentists were both operating in the dark, because the sleep physicians do not want to accept the fact that oral appliances could be effective in more than half of the patients. And as dentists, we haven't done enough to prove to them that we can select the patients prior to making an appliance and making them spend $3,000 or $4,000 on the therapy. So what I want to talk about tonight mostly is comparing the two therapies. We know for nasal CPAP it's efficacious, but as Dr. Gremmers would call it, it would be a barbaric treatment, poorly accepted, poor compliance. With oral appliances, it's not as efficacious, but it's readily accepted and better compliance. So let's talk about methods of patient selection in oral appliance that exist out there. We have oropharyngeal exam. We're looking at the Mallampati classification. We are looking at their tonsil grade. We're looking at their so many different things, how crowded the soft tissue are. But we know with those type of predictive mechanisms, we can only predict the failures. There are some studies that combine the obese patient with class 4 Mallampati, and we know an oral appliance is not going to work for them. However, it doesn't mean that it will work for them. Imaging of the head and neck, cone beam, all that stuff. There's a lot of research that is being done in that area. But again, we're not seeing the kind of accuracy that we need. Nasopharyngoscopy, we have different technologies such as pharyngometer, rhinometer. All of them, they give us a lot of good data that we can use, but none of us can tell us prospectively. That means that before we make the appliance, if the appliance is going to work or not. And CPAP pressure, that seems to be a predictor of failure as well if you have a CPAP pressure of over 11 or 12 centimeters of water. But the reality is there's no prospective study. There is no positive predictive capability. And the studies that were done, they were really small and they were uncontrolled. So up until today, we really have no other method of accurately predicting therapeutic outcome except with matrix. And Courtney has the next slide up, which talks about that for White's point of view, which is saying that the real problem is our current inability to determine if an oral appliance will work in a given patient. We should use a temporary and expensive device that we can do mechanical advance during sleep to determine the efficacy of the appliance. If it's efficacious, a custom device could be fabricated and used by the patient. And that is exactly what Matrix does. So the Matrix system, we're very happy to say that it does exactly what that slide was asking for. It's a remotely controlled mandibular protrusion device. So we're not waking the patient up. It is being done remotely through a different room. And we're predicting the jaw. We're advancing the jaw in 0.2 millimeter increments. And it allows us to accurately select the patients. And not only we know if the appliance is going to work for the patient or not, we can actually predict exactly at what location and what position, which is very exciting because we may not require as much calibration as we needed before. to make the appliance exactly at the position that is effective from night 1. You may not have to rely on the patient's response anymore. And another editorial that was done by Patrick Estrollo, and that was again this February, he mentioned that it is naive to assume all OSA clinical phenotypes can be treated with CPAP or other forms of positive pressure alone. Just as it is similarly naive to expect oral appliance therapy to be a standalone option. Personalizing care over time will require a variety of treatment options and adjustment therapy, as it is in the case with any chronic disease. And that's where medicine is moving these days to. We want to take a look at the patient and determine for that specific patient what is the best therapy. So that's where we kind of had the whole basis, and that's what was the whole philosophy behind it. So the way the workflow works, patient goes, sees them their sleep physician. They get matrix trays fitted, which I'll go through that later on. They go get a sleep study done. This is an in-house sleep study, so it's a full polysomnography. And the results are then interpreted by a sleep physician. And based on what we see from that airway, which is a passive sleep airway, that's very important to understand, because any other studies, any other imaging that we do these days, they're done on when the patient is awake. And when the patient is awake, their sleep airway has no correspondence to that. So the good thing about matrix is that the study is being done while the patient is sleeping, and we are looking at their sleep passive variance. And then based on what we see in those studies, we can predict exactly where the jaw needs to be. And if you go on the next slide, we can show that to you as well. And we're moving the jaw forward. You see the little apparatus is kind of exposed in the patient's mouth. We'll go over the trays. They fit very comfortably. It is very well tolerated. We looked at the sleep studies and sleep staging and see how many patients wake up or not. Very comparable to CPAP type patients. It's exactly similar to CPAP titration. And removing the mandible in 0.2 millimeter increments. And from that, we get a study back that allows us to look at all the sleep parameters. You go on the next slide, Courtney. And that's the kind of data that we're looking at. So instead of me talking too much about it, I just want to go through a couple of case studies, and I get back to the study and how accurate it was. So the first case study that I want to talk about is an obese patient with severe sleep apnea. 42-year-old female, pre-study AHI was 41.4, and their BMI was 32.3. So a patient that typically, if they walk in through the door today, based on our current guidelines, we may not think an oral appliance would work for them. And we may look at them and be like, okay, they only have about 7 millimeters of protrusive range. They're obese, they're females. The only good thing that is there, they're not too old. But the reality is when we did the study, we can look at their sleep study, can we go on that one? And that's how we basically look at the whole study and we figure out if they're going to be a positive success or a negative failure. What we're looking at their REM supine position, which is the worst case scenario for their sleep apnea. And based on that, we can make the prediction. If they have one or less events in REM supine in 5 minutes, that is the position that they're going to be successful with an oral appliance therapy. And quite frankly, after that, we made an appliance for this patient, and they were perfectly treated with very minimal protrusion. We basically had the protrusion at about 65% of maximum, and their AHI dropped down by 4. So this is the type of patient that we would have usually missed in our clinical practice. If a sleep physician would have seen this lady, they probably wouldn't have recommended an oral appliance, so we could easily treat this patient, as you can see. In another case, in study 2, we have a more of a moderate patient with an AHI of 17.9. Again, slightly obese, just like the last patient. And some people might have gone ahead and said they're in the moderate range and they have a good range of protrusion. So let's go ahead and make a sleep appliance for them. However, when we did the study, we looked at, doesn't matter how much we brought the mandible forward, we could not get rid of all the events. And quite frankly, when we made the appliance for them, there was no change, and they stayed at the failure, and quite frankly, they actually got worse, which there is a lot of discussions about why a patient would get worse, which we could be discussing about emergent central sleep apnea and many other issues like that. So let's talk about research and validation of the matrix. Is it something that we just tested in our office and we put it in the market, or there was a lot of studies done? So I'm glad to say, I'm very happy to say that there was a lot of studies done. There was 3 different studies that were done in the past 3 years. The most recent one that was done and published in the Clinical Journal of Sleep, it was a double-blinded, controlled randomized trial, 67 patients. And it was a prospective study, which means that the guidelines and everything was set prior to this study, which is the strongest type of a study, and that's what the FDA requires to approve the technology. And that's what we did the study, and it is published in the Journal of Sleep. So any of you that wants to see it, they can go ahead and take a look. But more importantly, what we found in terms of therapeutic outcomes in the study was, on the x-axis, you can see we have the BMI, and on the y-axis, you can see we have the AHI there. And we can see that there is no real distribution of who were the successors. So the green dots that you see on the graph, those are the people that ended up being successful, and based on their baseline of AHI. So you can see we have some patients that are close to 60. We have some patients that are close to 40. So there's a lot of severe patients. And then we have a lot of mild to moderate patients close to 10 as well. And the red dots are the people that were failures. And it didn't matter what we did for them with oral appliances. They didn't become successful. And you can see there's a lot of patients that are close to that line of baseline AHI of 10. And intuitively, we would have thought we could have treated them. That's what I used to teach to a lot of people, and that's what a lot of instructors are still teaching. If they're mild to moderate, go ahead and make an appliance. But you can see there's a lot of those mild to moderates that we could not treat. So there's no real distribution, and that was really, really interesting for us. So in terms of predicting outcome of oral appliance therapy, we realized that baseline AHI, BMI, or positional dependence didn't really make a huge predictive therapeutic outcome. Some of them were a little bit stronger in terms of adjusted next circumference and age were weakly predictive, but we didn't find any other correlation. So here's some more data, predicting outcomes. And when we look at this next slide, on the first graph on the left side, you're looking at the people that we predicted them as a successful therapy with matrix test. That means that they went, they got the test done, the test predicted them that they're going to be successful. We made an oral appliance, they wore the oral appliance, there was a follow-up sleep study done. And the second number of data that you see, that's their after treatment AHI. And you can see all those predicted successes, almost all of them, they ended up being a therapeutic success as well. And on the left graph, on the right graph, apologies, you can see the predicted failures. And you can see in some of them, although we had a huge drop, so maybe clinically, in real practice, we would have considered them a success, but none of them dropped below 10 and 50% reduction. So the test was very, very specific from that point of view. So we go to the next slide. In total, we had 32 predicted success, as you can see on the left side, on the left column. And out of that 32 patients that we predicted them to be successful, 30 of them ended up being therapeutically successful, which gives us a 94% positive predictive value. And on the right column, we have predicted failures, and we predicted 29% failures, and 24 of them ended up being actual failure. So as you can see, our negative predictive value was not as strong as a positive predictive value, but the study was designed for that, because what we're trying to do is, when we tell the physician, when we tell the patient oral appliance is going to work for you, we actually in fact want the oral appliance to go ahead and work for them. Otherwise, there's always a good alternative called CPAP. So in general, when we did the whole study, we realized that trays were really comfortable. We didn't have anybody having difficulty falling asleep with them, which was very important. And we didn't have any dislodging during the study, and that was controlled by the FDA as well. What we found was next, which we call it the thinking outside the box. And that is going to bring a lot of discussions to the table in the next year or so. Let's take a look at the top graph. On the left side, you can see their baseline AHI of the patients. So we have 0 all the way to the 8. And on the x-axis, we have basically their BMI. We're looking at the whole thing right here. The blue box that we see in the whole graph is what we call it the 30-30 box, which is the generalized guidelines for people that are in the mild to moderate range and people that are not obese. And we say that if those patients come to you for an oral appliance therapy, that's the common belief, we should make them an appliance. And if they lie outside that box, if they're severe or obese, we should not make them an oral appliance as the first line of the treatment. And you can see the blue dots, those are their baseline AHIs, and the green dots, are their AHIs after retreating with an oral appliance. When you look at the whole box, there's a lot of successes that lie in that 30-30 box. Almost 50% of people, they got treated successfully. But what was very interesting for us was there was over 50% of patients that lied outside those guidelines, and they were perfectly treated with oral appliances. So, for instance, if you look at the right side of the graph, there is a patient with a BMI of close to 40, and they were still treated perfectly. Right in the middle of the graph, you can see we have patients with AHIs of close to 60. And for those of us who've been doing this for long enough, we know this is true in our clinical practice. But it was very interesting for us to see that we can treat a lot of patients that lie outside those guidelines. Almost half of the patients that we can treat are outside that. And we can get very excited about it, but then we look at the graph right on the bottom. And you can see there is a lot of failures outside that box, which is good. That's the current guidelines today. But then you can see there's a lot of patients that lie within that 30-30 box. We have a patient right to the left of the graph that their original AHI was 20, and their BMI is below 20. And in real practice, we would think we would be able to treat them right away, but they ended up becoming failures. So almost half of the patients that were failures, they lied within that 30-30 box. So our guidelines all of a sudden become very shaky because it doesn't look like there is any predictive value. And it kind of makes sense in a sense because I had this discussion with Dr. Remmers not too long ago. And AHI and RDI is a number which is really based on what we call chemo-response or chemo-reflex. Well, the therapeutic success has to do with your pharyngeal anatomy during the sleep. So correlating AHI with success, it just doesn't make sense. But that is what our guidelines are based on. And I'm very curious to see how these things are going to change because our current guidelines are preventing a lot of our patients from getting oral appliance therapy. And also a lot of patients that are getting oral appliance therapy should not be getting them. So another study that I kind of put here is the status of oral appliance therapy in 2014 review. That's another study that was published in Journal of Clinical Sleep Medicine. It's a group called Orange Registry for those of you who do appliances. You know about that. There's a lot of great researchers and great instructors in that group. And they're following up the oral appliances and how oral appliances are getting better over time. And one of the important points that they talked about was patient characteristics relating to oral appliance therapy success and reliable prediction methods are a high research priority. So everybody is getting on the same boat. It's not about the shape of the appliance anymore. It's not about if appliances work or not. The question becomes, who is it going to work for, and how are we going to know before making it? Can you go on the next slide, Courtney, please? So and the second thing they came up with was the prediction test must be able to discriminate oral appliance therapy responders to non-responders. And predicting oral appliance therapy responders to a sleep study using remote control and with advancement is promising. So we were happy to see our name and our research in that as well. It was a very independent paper that was done, and we're glad to see that we are on the same page with these guys. And in general, when you look at the important points that Orange Registry identified was, overall, the initial study using this device as a prediction tool shows a good accuracy in identifying patients who will be fully treated with oral appliance. So I was going to summarize what we're looking at in terms of clinical benefits of Matrix. We're basically offering a viable solution for CPAP intolerant patients and refusal. We are empowering patients to make an informed choice for oral appliance therapy, knowing if their appliance is going to work for them or not. And the biggest important thing is it's going to be immediately optimizing and improving confidence in oral appliance therapy. It's going to be a lot easier when you tell your patient that I'm going to make an appliance and it will 100% work. And you don't have to rely just on me telling you, trust me, I'll try to make it work for you. And in general, we're trying to improve long-term treatment compliance and therapeutic outcomes. The second point that we talked about earlier was the dentist doesn't know where to set the mandible. So how are we going to solve that problem? And that was one of the other things that I want to talk about. Right now, there's different bite registration techniques. There's so many things that we talk about. In my courses, I categorize them in two different areas. I call them dynamic and static. What do I mean by dynamic bite techniques? For those of you who are doing it, there are people doing what we call phonetic bites, swallow bites, TENS bites, neuromuscular bites, comfortable position, snoring bites. You can go on the next slide. And These are all the different things that I kind of categorize as dynamic bite techniques. That means that we're dealing with the muscles and where the jaw wants to be. Or we'll do what we call static bite techniques, which is George gauge, Andre gauge, airway metrics, which has to do with the range of protrusion. And then we go on and try to find the starting point. But the reality is there's no correlation between BMI, RDI, gender, or anything that has to do with the level of protrusion. And then we start titrating these patients. And we titrate them based on subjective symptoms. If they have any discomfort, level of snoring, level of symptoms, and then we titrate them comfortably until the snoring is gone, until symptoms have improved. And then from there, we'll go tell them up to 2 to 3 millimeters per month. Go slowly, keep track. If symptoms are there, go a little bit further, take a break. Then we start thinking about TMD anatomy. We'll look at how the joints look like and where to put the jaw. Then some of us went on and start talking about tensing and getting the nerves and everything comfortable. Then we start going over different appliances. We have different adjustment mechanisms. But the reality is, the bottom line is, we still don't know where we're trying to fit the mandible. We're just chasing for that magical moment, for that sweet moment, for that aha moment. And I love this quote. He says, if you don't know where you're going, you'll end up someplace else. And I felt like that in my practice for the longest time. I keep on asking the patient, oh, how do you feel? Half of our patients are asymptomatic. So what is the value of asking the question of how do you feel? And then the biggest other side is, again, side effects, which now we know it is quite related to amount of protrusion and how we make these appliances. And then we started panicking about how to manage these side effects. And we tried to get our priorities. I love that picture. Just taking the picture. Can you go on the next picture? I love that one. It says, take the picture, then save your child from being eaten alive. There's this little camel that is eating the whole son. But that was kind of our model right now in dental food medicine. We're telling them, okay, let's get it comfortable for you. Let's get our priorities straight. And then we're going to move on and we're going to go further to see if we treat it or not. How about if we change the whole thing? How about if we started at a better position? How about if we just went to that position that the appliance is going to be successful from the first night? Wouldn't that be nice? And in the study that we showed is, let me go back to that study.
Oh, sorry.
That slide. No, that's okay. If you look at that whole thing, if you look at the left side, you look at the baseline RBI, and then we look at the voluntary protrusion. A lot of us are starting our patients at 60 or 50 or comfortable position level of protrusion. But the study showed almost half of the patients will be over protruded at that position, which means that they didn't need that much, which is very consistent with the new way of looking at oral appliances, which is they're not a protrusive appliance. They're just stabilizing your mandible from falling backward into your pharynx. We can go on to the next slide, Courtney. So what is the dentist benefit? Not only we can pick the right patient, now it can actually have immediate therapeutic effects from the night one. So we make an appliance that is going to be effective from night one. And we may not need to calibrate or titrate our patients anymore because we know exactly what position this appliance is going to work. I call it a more objective bite registration and titration. So we know what we're doing. We're measuring things. And one of the other things that we found that was very interesting to us was we found a lot less discomfort in side effects. And we think the reason is because the patient was treated from night one, there was no residual OSA, and they felt better. So the next graph that Courtney has up already is it shows the accuracy of target therapeutic position. So what do we mean by that? Patient did the MATRx A study. The study was done and interpreted by a physician, and the physician told us at this amount of protrusion or at this level of protrusion, the patient is going to be successfully treated. We went in there, we did a bite registration exactly at that position, made an oral appliance, gave that oral appliance to that patient at that setting. Didn't do any calibration, didn't do any titration after that. Did a follow-up study 3 to 4 weeks later, and we figured out almost every patient ended up being successful at that target. And you can see there was a huge range of target on that. And in terms of the numbers, you can go on the next slide. We had 31 predicted success, and out of those 31, 27 of them were therapeutic successful from night one. And if you go on the next slide, again, we found the data that shows that the level of protrusion has nothing to do with their AHI or their BMI. So So if you look at the left graph, it has the AHI on the left, and we got the level of protrusion, and same with the BMI graph. And you can see there is a really wide range of distribution there. So if a patient walks into a clinic tomorrow and they have a high BMI and a high AHI, it doesn't mean that we're going to push their jawbone forward. Or if they come in and they have a low AHI and low BMI, it doesn't mean that it's not going to require as much protrusion, and they may actually, quite frankly, require 100% protrusion. So I thought it would be kind of cool to compare the treatment protocol, the conventional treatment protocol that we have, with how would Matrix change this whole thing. And when I look at that, right now, I might change from office to office. So one of the more common protocols is we see the patient for our initial consult, we bring them back, we'll do the records. A few weeks later, we have the appliance delivery. We do 2 or 3 follow-ups in the meantime, and 2-3 months down the road, we do a follow-up sleep study and a final consult, and then follow-up 6 months or 1 year after that. With Matrix, we'll do the initial consult. We don't have to talk about oral appliances and if they work or not. All we're trying to do is fitting the patient with the Matrix tray. They go, they do the study, and if they're in fact going to be a therapeutic success, that's when they come back to you and they do the records. And we'll do the bite registration, objective bite registration. We'll give them the appliance on the 3rd visit. And what I do in my clinic right now, I'll see them 3 to 6 weeks later, just once, just to make sure their jaw is okay. And I know they're treated at that position because the target was predicted by the Matrix study. And I just do a follow-up sleep study just to confirm that so I can send that back for my sleep physician. So I'm basically cutting a lot of time out of my chair time. And I don't have to deal with a lot of failures, quite frankly. We all know 80% of our time is being probably used on those 20% of patients that we cannot treat. And the rest of the patients that they go well, we're doing good with them. So in terms of business benefits, we're seeing it in terms of saving a lot of time. We're eliminating appliance failure. And quite frankly, we're differentiating the dental sleep medicine practice by telling the sleep physicians that this is the right way and there is no guesswork in how we do it. So I stopped comparing the Matrix protocol, the conventional protocol, because quite frankly, I think they're 2 different things. The only thing that is common between the 2 of them is an oral appliance. And we're not saying the oral appliance therapy is a dead thing. We actually believe in oral appliance therapy, and we believe a lot of patients need that. But with Matrix, we don't require all those guessworks, all those subjective guesswork titrations. We're going there, we know it works, and we're just going to follow up with it. The next slide I have, they talked about second industrial revolution. Why do I even talk about this? I saw this one in one of the TED Talks. I don't know, I'm sure some of you watch TED Talks on the podcast. And it was very interesting, and I kind of find that very similar to what we're trying to achieve here. And the second industrial revolution, they replaced all the steam engines with power engines. But it took over 30 years for the efficiency and profitability of these companies to go higher. They did a study a few years ago, and what they figured out was the reason the productivity and the profitability didn't go up, it was because nobody changed the pathways, nobody changed the protocols of how these factories were run. And they're trying to use a new technology in the old workflow, and that didn't change. It almost took 30 years until we had new managers in place that they changed everything. So the reality is, again, we want to think outside the box. We don't want to put that in oral appliance therapy. We want to change the base of that. We want to actually look at it differently. Patient comes in, if they prefer an oral appliance over a CPAP, regardless of their BMI and AHI, they should go for a Matrix test. Maybe an oral appliance is a better option than CPAP for them. And then objectively choose these patients and give them the right therapy. The next slide is, I love this slide because I like playing chess. I used to. I don't do that often anymore. And there was a full competition done about 12, 14 years ago. For those of you who know chess, you probably know Garry Kasparov. He's from Russia. He was the defending champion for many years. And they put him against the computers. And every time they did a computer had a match with Garry Kasparov. Computer won every single game. Then what they did, Garry Kasparov went and created a team of a bunch of chess players that had computers, and they went against computers and they went against humans. And what happened is the team that had computers and humans ended up winning every single competition as well. And what I'm trying to say, the technology is not going to change what we do. The technology is not going to make us better until we use it in the right context. So we still need the dentist. We still need our expertise and everything that we've learned. But it just makes us this much better. And in summary, I just wanted to say that gold standard changed. Growth is not dead. CPAP has been a gold standard for many years. It doesn't have to be a gold standard. Oral appliance therapy, we know it works. We know it's more readily available. We know patients like it. We know compliance is higher. And the only problem we had was not knowing who it works for. And now we have that answers as well. And how is it going to help us? We can have an effective treatment from night one. We can optimize oral appliance from night one. We don't have as many failures. And non-responding patients can avoid expenses. That's huge. Time and inconvenience of failure of appliance. So that's one of the biggest factors that ruins the trust between a dentist and a sleep physician. And in terms of accuracy, it's been extremely accurate in terms of predicting the therapy outcome and also knowing where to set the mandible. So I'm just going to go through the next 10 or 15 slides pretty quickly. It just shows the system. We have a remotely controlled mandibular position and temporary trays, and the controller lies outside the room. On the next slide, it shows the trays really closely. So we have a whole range of motions which we can determine. We can tell the lab where to work within so they're not going to over protrude the patient. And we have the incisal grooves right in the middle as well, so we can have an accurate reading and accurate position of the jaw. On the next slide, it shows you basically an edge-to-edge position. This patient would be reading a number 10 on the scale, and we use that as our reference point, for instance. The trays are fitted pretty comfortably. There's trim lines. We can change the size of the tray. We can use some heat to move them around a little bit. Comes in different sizes. In our study, we used Blue by HP by Amy Shine. Fit the trays really easily and started trimming them. What we want to try to do, we want to keep these trays as small as possible and trim them really, really nicely so it kind of mimics an oral appliance as close as possible. Then you take a look, you make sure there is no sharp spots or anything like that in the patient's mouth. The patient wears the trays, moves forward and backward, and based on that, we'll do the measurements. So in this patient, you can see their range of motion is going to be from 12 all the way to 16. Not a very big range of motion, but you basically relay that information to the lab, and the lab can get to use that. It's a small little card, you write everything down on that one, you rinse the trays, and you put them back in there, and off they go for their matrix study. And when they come back, we have all the data that we require, and based on that, we can make that fine. Just want to take a time and just thank everybody else that helped me with the whole research here. It was the primary investigator is Dr. John Remmer, and it was a pleasure working with him on this study, and we had a lot of better supports there as well. So I think I kept my promise. We're at exactly 40 minutes, and I am done.
All right. Thank you so much for all of that great information, Dr. Charkhandeh. That was just a wealth of information, and I know I learned a lot.
Thank you. It was my pleasure.
Now, at this time, for everybody on the conference line, what I'm going to do is go ahead and unmute everybody's line. If you'd like to jump on the conference line and ask Dr. Charkhandeh any questions about the matrix or his experiences, feel free to jump on the line. If you don't want to be unmuted, you can feel free to just mute yourself right back. And if you have a question, please feel free to type it into the chat box in the lower right-hand corner of your screen. So at this time, I'm going to go ahead and unmute everybody's lines for them. Okay, great. So everybody should be unmuted. Is there anybody on the line that would like to ask Dr. Charkhandeh a question or share an experience?
Yes, I would. I'd like to know what a scenario would be of implementing the matrix in one of the sleep doctor's offices.
Is this Elsa? That's
Yes.
available?
Yes.
Okay. So I'm just, what do you exactly mean in terms of implementing in the doctor's office? Are you talking about the sleep labs, or are you talking about...
Right, the sleep lab is...
So basically, we are at around 85 centers, sleep centers across U.S., I believe, as of now. I probably wouldn't have the exact information that marketing people would do. And if there is a lab that is closed, where do you practice actually?
In Florida.
In Florida. So I'm not really sure if they have a lab or not there, but you probably do. If they do, then the whole question is going to become us introducing you to the lab or you introducing yourself as a doctor that is doing that, and you refer your patients for the matrix study to them as well. So if you have a lab that you work with closely and you would want to get a matrix system in that place, just contact the company, which would be ZephyrSleep.com. That's the company that makes the product, and we would be more than happy to get in touch with them, with salespeople that would be able to help you with that one. If you want, you can email me directly, and I'll put you in touch with the right people. I'm the research guy, but I'm sure our salespeople will take care of you really well.
Okay.
Yeah.
Thank you.
So basically, we'll require a sleep lab to have the matrix system because the test is not like sleep condition.
Shouresh, could you give the approximate cost for the sleep lab? For the matrix?
Don't quote me on this, Rose, but I'm terrible when it comes to numbers. The approximate cost of the whole system, the actual matrix system, is between, I believe, $5,000 to $7,000, and that's the one-time fee. Includes the implementation, includes the training, includes everything, because it gets incorporated into the existing software. So if they're using a certain type of software for their CPAP titration and for their PSG, they end up using the same software, and we kind of incorporate it in that. And then there is a cost of the trade. So every patient that comes to see you, there is a small cost to those trades as well. I believe that it's in the range of $60 to $80 per trade. And that's either covered by the patient, sometimes insurance, sometimes I know the dentist cover that because it saves them a lot of time and money in terms of follow-ups.
Sure.
Right, and from my understanding, I don't know if this is right, Dr. Charkhandeh, that the cost for the matrix system on the lab is really not a huge cost from what they're used to seeing for other types of diagnostic systems in their side.
Absolutely. It's not that big for them. It's just a matter of getting in touch with them and knowing the right people. And a lot of times with the hospitals and medical centers, they really rely on research and basically nicely validated technology. And the good thing about Matrix is we have a lot of good data and good research behind it. So as long as we know who the lab is that you guys work with and everything like that, I'm sure we'll be able to help to get that in that place.
Okay, great. I've got a great question, Dr. Charkhandeh, that just popped up in the chat box. And the question is, does the study vary the vertical dimension as well as horizontal?
Okay, in the first study, the 67-patient clinical trial that we published, we did not incorporate the vertical in there. However, what made us very happy was, at the end of that study, regardless of changing vertical or not, we still had about 65% predicted success, which is very consistent with a lot of old analysis. So it doesn't look like we're missing a lot of patients. Also on the vertical side, I know there is some data out there, but there's not a lot that suggests that vertical does make a big difference in therapeutic results. It does make a difference in comfort, but I personally have not seen strong studies that would show that increasing vertical will definitely change the therapeutic outcome. We're doing a 167-patient clinical trial right now around that number. And in the second study, we actually incorporated vertical as well. So we tried the same patients at different verticals, and we followed up to see if actually vertical did make a difference
Oh, that's
in terms
great.
of the therapeutic success. And we haven't published that. We've got to do still statistical analysis on it. But so far from what I can see, we don't get to see a big difference in terms of vertical. And I know a lot of people. So the study is done at basically 3.5, 4 millimeters vertical, which a lot of clients will be made at right now. In my clinic, I'll just use the AP information that I get from the study, and I set the vertical based on the patient's comfort, and it seems to be working really, really well.
That's great.
Can you hear me, by the way?
Yes, who's this?
Okay, when you send the patient to the laboratory, you give them the guidelines as far as which positions, not a protrusion. Do you have incidences where when the patient's sleeping, you're moving the drug too far and it causes them joint issues?
We didn't have any in our clinical trial. And because everything had to be actually really followed up closely, we had to record every data and every incident. Unfortunately, knock on wood, it hasn't happened at all because the dentist determines that range, right? So we, of course, have to rely on the expertise of the dentist as well, but we didn't have any major incidences at all. We had a few patients that had some sort of a jaw discomfort the next day, but most of them went away by around lunchtime, by around noon. So, and from the clinical practice that I do out of Calgary and Edmonton, haven't had any issues like that.
And what sort of charge do you give the patient for this extra service besides the cost of your oral appliance?
That really depends on your practice. For me, I actually don't charge them extra. I don't. When my patients go ahead with the MATRx study, I actually reduce my price to a certain point because I know I don't have to visit them 5 or 6 times after, and there is no titration. But I know there are people that are charging between $70 to $100. And quite frankly, if you train your team, you can get them to fit the trade, and all you have to do at the end of it is just go in and check it. So it shouldn't eat your chair time too much because you're not doing really any predictive thing. You're just going in there, counting the number of the teeth, making sure there is no periodontal problems and no severe TMD issues that will contraindicate all appliances, and then just fit them. And it usually takes about 4 to 5 minutes in total to fit these screws.
And through medical insurance, you could use the same code you're using your initial screening.
Yeah, I'm pretty sure you can actually use that, exactly. So Rose would be better to answer that.
Sure. You could use like a level 2 evaluation in medical.
Yeah, and also Rose, I've in the past I built out a set of matrix trays before, and particular insurers, if you go ahead and bill it out under 99070, that miscellaneous supply code, and just write a little nice narrative letter, just a little note letting them know what those matrix trays are. It's been paid under 99070 as well.
We do commonly see those paid for impressions, and that's another code that actually had popped in my head as well, Courtney.
Yep, it's always a handy one to have in your back pocket.
You're way better than I am, I tell you. Honestly, it goes back to the whole thing that I was talking about. It's just changing the protocols and the workflow. Because right now we're just thinking about this in the context of conventional oral appliance therapy, which in reality, when I look at my practice right now, we're getting at least 3 or 4 times more referrals to some of this. Now we're not looking at 5% of oral appliance therapy out there. We're looking at hopefully having 40 or 50% of patients by educating our doctors that, you know what, go ahead and do that. So we don't have to deal with heart patients, and we don't have to worry about the $40 or $50 tray charge, because maybe instead of 10 appliances, you could be doing 50.
Right, great point.
That's the biggest hurdle. That's what I've seen for a lot of people. They're trying to slowly incorporate it, and which is fair, and I've been there myself. But it's just differentiating yourself from other people that are doing oral appliance therapy and telling them, you know what, when the patient comes see me, they're going to be successful, and hopefully instead of 5% of patients in the next 5 years, we're going to end up seeing the 50% of patients that should be on oral appliance.
So it goes back to the whole thing, practice good medicine and the patients will follow and the money will follow.
100%.
All right, great question, Dr. Feigenbaum. Thanks. Does anybody else on the line have any questions or comments? Okay, great. Well, thanks for everybody for joining in and your input. And just wanted to remind everybody, especially if you liked what you heard tonight, please try to join us with Dr. Charkhandeh in Chicago. We're going to have a great 2-day successful implementation of dental sleep medicine course, and you can see a lot more of Dr. Charkhandeh during that. It is 16 CE credits, and you can contact Nearman Practice Management to get yourself and your team hopefully signed up for that. So hopefully we'll see most of you, if not all of you, there.
Thank you all again for being here. It was a pleasure talking to you all. Any questions or anything that comes up, Courtney, feel free to pass on my email address to anybody that is interested, and I would be more than happy to direct them to the right people or answer it. just for the course, I just wanted to make that simple. The course is going to be, again, a lot of information on the conventional oral plant therapy. And there's about 2 hours of it that is dedicated to Matrix. So there's still a lot of stuff that we need to learn because we understand Matrix is not all over the place yet.
Right. Cool. Well, we're looking forward to that so much. And thank you so much, Shouresh. It was a great and very informative webinar.
My pleasure. It's been a pleasure to be on the line with you guys all and talking to everybody.
Well, thank you. This is very good. Thank you very much.
Thank you.
Thank you. Thanks everybody for joining. And if everybody has free time next Tuesday evening, our next special guest host is going to be Dr. Mayor Patel. So next Tuesday on April 1st, he's going to join us at 6 p.m. to talk about dentistry's role in screening for OSA and TMD. And as our fun little special day or holiday for today, we have a couple celebrity birthdays on March 25th. Elton John turning 66, Danica Patrick 31, and Sarah Jessica Parker 48. So there's that for this week.
Courtney, you're so much fun.
Well, again, thank you so much, Dr. Charkhandeh. It was really a pleasure having you on the webinar with us.
Thank you, Courtney, and thank you, everybody. Have a great night, everyone.
Good night.